Hello, everyone. Welcome to the Independent Stage briefing. I'll start with a bit of good news. COVID-related hospital admissions have started to level off now, according to the NHS England figures. They had risen steadily for a month, but now they're plateauing. Less good news is that ONS data shows that COVID-related deaths were up by about 40% compared to the week earlier, with 400 deaths recorded, of which over half were the underlying cause of death. So if you haven't had your booster, please go and get one. Worse news, in child health, which is my background, we talk about the malnutrition infection complex, whereby bad nutrition predisposes to infection. Well, we have 14.5% food inflation. We have the worst UK hunger crisis in living memory, especially for women and children. Record numbers of families in income poverty, food banks unable to meet demand, and teachers reporting many more children arriving at school hungry. This cannot be good for all kinds of reasons, but including resisting infection. Today, our session is going to discuss concerns specific to women's health. And for this, we've got four fantastic expert guests joining us today: Dr. Viki, Dr. Teresa Kelly, Dr. Louise Newson, and Dr. Nighat Arif. And I'm really looking forward to that. But as always, we're going to start with our numbers segment, presented today by our numbers nerd, our guru of graphics, Professor Christina Pagel. Christina.
Hi. All right, let me share my screen. Right. So I'm going to try and be quick today because we have amazing guests. So I'm going to start by just going over prevalence and then hospitalizations and deaths, and then spend a bit of time on vaccinations and then a bit on vaccinations and pregnancy, given the topics that we're discussing today. So the latest ONS infection survey came out today. This is for the last year, and this is where we are now. So you can see that Wales here is highest. It's about 1 in 25 people had COVID in the week ending October 11th. Remember, this is always a couple of weeks behind now. And it's lowest in Northern Ireland, where numbers have also been flattening off, and we're kind of lower than we have been in previous waves at the moment. In England regionally, we've got most COVID up in Yorkshire and the West Midlands, and the least in London, but really it's pretty much about between 3 and 3.5% across the country, which is high, right? It's about 300, 1 in 30 people. Now, looking at it in age, we see quite a lot of variation, especially lowest in school children. But what is good news this week is that last week we had really high numbers in the over 70s, and these have started to come down as of the second week of October. And so this probably could be because of the booster kicking in, which is really good news. The less good news is that they're increasing fastest and highest in adults aged 50 to 69. Now, all of these people are not eligible for their autumn booster, so please go and get boosted. It really does work and help. Just wanted to say something about children. As I said, they had the lowest rates, and this is just showing infection in primary school and secondary school kids. The yellow are the holidays, and you can see we've had a much smaller back to school bump this autumn than we've had previously. This is obviously really good news. I suspect it's because we've had really high infections in these age groups for the last 6 months, which is less good news, but at least we haven't seen a really big back to school effect this year. Now, it's likely that the wave that we're kind of at the top of at the moment, kind of a modest wave, is driven by waning immunity and people moving back inside after the summer. There are new variants rising though. The main one now here in the UK and Europe is BQ.1.1 or BQ.1, and they plus BF plus .7, which is the other increasing variant in England. And now, as of kind of second week of October, about 17–18% of sequence cases, and it's going up. So at some point, they will become dominant and likely drive a modest wave. But again, you're kind of seeing more immune evasive variants hitting a more immune population as we're boosting. So it's not really clear how those two things are going to play off against each other, but we will be finding out. In terms of hospitalizations, across the UK, they are flattening, they're coming down in Northern Ireland, although this only goes up to the 13th of October. Even in Wales, which has been, you know, the country that's increasing the most in terms of prevalence, you're seeing it looks like a recent plateau. So the number of people in hospital is flattening off now. In England, you can see over the last couple of weeks that they've coming down. Now, it's not some kind of massive descent. It's still high numbers of admissions. It's still causing strain on the NHS, but it is starting to come down. The question is it going to be going up again once the new variants come into play? Now, what's interesting about the UK admission, the English admissions as well, is that this drop seems to be driven mostly by actually better infection control within hospitals, as more hospitals are starting to use masks and other infection control measures. This is a chart from Oliver Johnson, Bristol stats professor there. The red line is community acquired hospital admissions, and the blue line is hospital acquired admissions. So people who get COVID in hospital when they're already there. So a third of all COVID hospitalization, so it's quite high, but you can see that this is coming down, whereas community acquired is pretty flat. So actually it looks like what we're seeing is not so much that COVID is coming down in the community, but the hospitals are getting better at preventing infection within hospitals. In terms of deaths, the recent week has seen an increase, actually seen an increase in pretty much all nations responding to the September wave. It is a modest increase, but it's still, you know, more people dying than, well, obviously we don't really want anyone to die, but you can see hopefully this will flatten off. And even if we get a new wave, I'm hoping we're not going to see this big spike in deaths because we have been boosting. So let's have a look at the vaccination data. This is the progress of the autumn booster across the UK. England and Scotland have now boosted almost 2/3 of the eligible population. It is lower in Wales than Northern Ireland. So this is, I don't know why, but this is potentially something that could cause issues, particularly for hospitalizations there among older populations. And if we look at England stats by age group, because obviously the over 75s became eligible first, see almost 70% of them have now had their autumn booster, over half of 65 to 74-year-olds, but only a third of 50 to 64-year-olds. So these two are the age groups which actually have the highest COVID prevalence right now. So please do go and get boosted. And the UK Health Security Agency also released data this month on looking at how long it's been since people have had their vaccine dose, because the vaccine effectiveness data says that after about 6 months, you get much less protection from your vaccination, particularly against infection, but also protection against more severe outcomes does drop. It doesn't go to zero at all. It's still worth having, but it does drop. And if you just look at that by age, so green, if you've had a booster more recently or a dose more recently, and orange as if it's been more than 6 months, and red as if you'd never be vaccinated at all. And you can see obviously that the older populations have had much more recent doses, but we do have now a lot of adults who actually have not had a vaccine dose in more than 6 months, and so who are more vulnerable now to new infections. And in children, and primary school children, we're still seeing most of them have not had any vaccine at all. We can also see quite a big difference by ethnicity again. So among Black British people, you can see that actually 44% have not been vaccinated at all, and almost half have actually been more than 6 months since their dose. So now just looking at pregnancy. So first, from the UK Health Security Agency, in their monthly vaccine surveillance report, they do have a whole section on vaccine coverage in pregnancy. And they highlight the risk of COVID. You know, they highlight that the American Centers for Disease Control and Prevention found that pregnant women were around 3 times more likely to be admitted to ICU and nearly 3 times more likely to require invasive ventilation compared to non-pregnant women with COVID-19. So pregnancy adds risk if you get COVID. But vaccines do work. There's plenty of evidence now that they offer a very high level of protection against infection in pregnant women, and that they prevent severe outcomes. And there's actually also evidence that if you've been fully vaccinated, it can help prevent hospitalizations in the newborn baby until it's about 6 months old. So this is data on women who gave birth between April and June this year, and how many of them had at least one dose of vaccine, that's the green, by deprivation. So these are the most women in the most deprived areas and women in the least deprived. And you can see there's a really big gap, with almost 40% of women in the most deprived areas giving birth not being vaccinated at all, compared to only about 15% in the least deprived. And again, you see a similar pattern by ethnicity that we saw for the whole population. And so this means that we have more vulnerable pregnant women actually at much greater risk of get COVID. And remember that they're also more likely to be exposed to COVID through their daily lives. And just something on outcomes, which also is reported by UK HSA, just to reassure that actually there's no evidence that vaccination is associated with worse outcomes for the baby. This is stillbirths experienced by women giving birth between January 2021 and June 2022, by whether the woman had had any vaccine doses during pregnancy or not. You can see actually women who had at least one dose experienced slightly fewer stillbirths than women who had no doses. Now, it doesn't necessarily mean that's because of the vaccine. The numbers aren't broken down by whether these women had COVID during pregnancy. And we also know that there are big differences by deprivation in terms of who got a vaccine. But there's absolutely no evidence here that the vaccine isn't very safe. And this data supports other studies showing really high levels of vaccine safety in pregnant women. And this is also just another chart showing something similar, but for prematurity, showing that actually women who had one or more doses in pregnancy were less likely to give birth either prematurely or very prematurely. So just one more final slide on flu. We've talked a lot about COVID, but the UK HSA also released data on flu, and this is the flu winters that we get normally are worse than January and February each year. This is a proportion of people testing positive for flu. This is 2019 to 20, so just before the pandemic. 2018 to 2019, a slightly later, slightly higher flu peak. Last year, we didn't have a flu season, really. It was very low, and we had absolutely nothing in 2020, 2021. This is this year, and you can see we're already tracking higher than the 2 years before the pandemic. So this year we're going to have a flu season. So please get your flu vaccine if you're eligible, because flu is also a nasty disease that you do not want to get. So just to summarize, we've kind of seemed to have reached a plateau in this wave. It's probably the waning immunity wave that's peaked, and the autumn booster has helped that a lot. In the next week or two, maybe 2-3 weeks, we will have new variants being dominant in the UK. That could drive another wave, but how it interacts with the autumn booster remains to be seen. We kind of have more immune evasive variants colliding with a more recently boosted population. France is a bit ahead of us with these variants, so we should hopefully get a clue from them as to what we might expect. Singapore is currently in another different Omicron subvariant wave called XBB. We don't have much of it here, but if it comes, we don't really know what will happen then either. And finally, flu is on the rise again. So if eligible, please get your booster. And also remember the things that work against COVID, things like fresh air, masks, not going to work if you're sick, also work against flu. And I will end there.
Brilliant. Thanks so much, Christina. Some really interesting data. But I'm going to go straight over to Dr. Zubaida Haque and Dr. Binita Kane to introduce the whole session on women's health and COVID. So I think Zubaida first.
Hi, everyone. Thank you, Anthony, and thank you, Christina. Yes, we're really excited about today's session because it's long overdue and it's really, really important. We've known, of course, for a long time that the pandemic has had a markedly different impact on men and women. And last year, we talked about the economic impact and the impact in the workplace on women last year in June, 25th of June, so do look that up. But this year we thought we need to focus much more on health, because the data on women's health and COVID vaccines, COVID vaccine uptake is still really, really concerning. Now, as Anthony mentioned at the beginning, we have 4 amazing speakers with us today. We have Dr. Viki, who's an immunologist working on reproduction and pregnancy at Imperial College London. Viki, give us a wave.
Hi.
We have Dr. Teresa Kelly, who's a consultant obstetrician and a lead for maternity COVID vaccination in pregnancy in Manchester. Hello, Dr. Teresa Kelly. And we have Dr. Louise Newson, who's a GP and menopause specialist with an interest in long COVID and hormones. Dr. Louise Newson, could you give us a wave, please?
Hello, thank you.
Great. And last but not least, we have Dr. Nighat Arif, who's a celebrity GP, who many of you have probably seen on TV, both BBC and ITV, and who specialises in women's health and equality and inclusion issues in relation to health. Now, Dr. Binita Kane is going to tell us a little bit more about the session. So, Binita, I'm going to hand over to you.
Thank you very much, Zubaida. And yes, I'm excited to have our brilliant guests. And I think women's health is often dismissed and definitely under-researched. And when you look back at history, a lot of conditions that affect women have been in the past written off as hysterical until we've discovered actually there's an underlying cause. And women, when it comes to chronic disease, are often disbelieved. And I know lots of people with long COVID are facing that at the moment. And if you're from a minority ethnic group, that tends to be a worse experience. And I've seen this with my own eyes over the last couple of years. I'm in touch with a lot of mums. I've been advocating for my own child, and many mothers have sort of felt that they're seen as over anxious or part of the problem, not being taken seriously. So when it comes to women's issues in general, I think there's a lot of work to do, and menopause is a really good example of a condition that affects 50% of the population, yet remains quite taboo and undertreated and under-researched. So without further ado, we'll get on to our guests, and I'm going to come to Teresa first, if that's okay. So Dr. Kelly, you're a consultant obstetrician, and you've got an interest in COVID vaccinations in relation to pregnant women, and you've led a fantastic program in Manchester. Women are naturally nervous about having the vaccination when they're pregnant. And so can you tell us a bit about your experience over the last couple of years and what the pros and cons of vaccination are?
Yeah, thanks, Binita. I think it's a really good topic, and people are always hesitant in pregnancy, and we need to get information out there to help them. So I think when we started with COVID in pregnancy, in my experience, we didn't actually have many people who were pregnant sick in hospital in the first wave. For our age group, a lot of people were at home, the kids weren't at school. There were some admissions to intensive care, there were some people getting sick, but that's not really when we started seeing the problems. Once people started mixing again, the kids went back to school, we started seeing more people with COVID. When we got round to testing everybody, we would have quite a lot of people who were positive for COVID. Most of them were asymptomatic, but we had a significant number of sick people, and we had the difficulty of knowing where to look after them. We didn't have much expertise in obstetrics of looking after people with COVID. So at first people were going to the medical wards where people were used to looking after them. And we found there was a real problem with doing that because their babies were getting distressed. We weren't getting down to see them, and realised we really had to have them on our maternity unit. We've got HDU rooms there, and we have to look after them then, because even when we thought sometimes the mums were stable and they were undergoing treatment, the babies were getting distressed quite quickly. And it was sometimes amazing that you would be watching somebody who you thought was getting better and their baby was just getting sicker and sicker, and you had to go and deliver their baby really quickly. It kind of gradually got worse after the Christmas. Remember when we had to shut down again after Christmas? We had a big peak in that January, and we had a lot of people in who were sick, and we're really balancing the needs of the mum, and the baby. And the treatment for COVID, we were giving people medications that you'd rather not give to them. I mean, a lot of them are safe, but, you know, for example, we're giving steroids and we didn't use dexamethasone because that crosses the placenta unless we were going to deliver the baby. So we were giving them prednisolone, giving them quite high doses. And I think almost everybody we gave prednisolone to needed treatment for diabetes because it affected their blood sugars, which affects everything else. So we had some really difficult cases. We had some horrible cases. We knew from, you know, other colleagues what was going on. You know, I'm a reviewer for the maternal death National Confidential Inquiry. So, you know, I'd known from quite early on from the first wave, even though I hadn't seen it myself, that young people were dying from COVID in pretty horrible circumstances. One of the lessons we were quite used to vaccinating in pregnancy. The lesson we learned from the swine flu epidemic was that we should offer flu vaccines in pregnancy. So we were used to doing that. We were also used to giving whooping cough vaccine because we realised that babies were getting whooping cough before they could get their own vaccine. And we give them whooping cough vaccine. We've been giving that since 2012, I think, so that babies get their mum's antibodies and they're protected before they can get their own vaccine. So vaccination has very much been a part of pregnancy, good antenatal care for quite a long time. We are aware that when people are pregnant, they often don't get the medical care that they would get when they're not pregnant. And one of the big lessons from other people, from people say having cancer or respiratory problems, is that actually if you don't give them the right care that they need, then people do worse. And actually people should be having the choice of having the care that they need and balancing it with the needs of the pregnancy and making sure they get the right care. So when the vaccination came out, initially on the 8th of December, pregnant women were excluded from it. And I think in the UK, but they weren't in the States and in Israel. And there was a lot of disquiet about that. And that was very quickly changed so that anybody who was pregnant or trying for a baby or breastfeeding from the 30th of December, so it was less than 3 weeks that we weren't advising vaccination in the UK, that we could. So we started rolling out from January 21 to people who were pregnant in the high risk groups. And I had lots of staff and I had lots of people at our clinics. We targeted our clinics, women with severe cardiac disease, respiratory disease. We started giving it to them, and then we rolled on into February, giving it to women who had diabetes, who'd raised BMI. It was an uphill battle and it was difficult, but I think as a consensus, as a maternal medicine team, we were all very keen to make sure that women were protected, that they knew what the risks and benefits were. We were pretty convinced that this was, if it was safe when you weren't pregnant, it would be safe when you were. We didn't think it would cross the placenta, and gradually as it went on, we got more and more safety data. And you know, fortunately, when it came to April 21. We were allowed to give it to people based on their age alone, and we managed to roll it out. Unfortunately, about that same time, Delta hit, and by sort of July 21, there was a big peak of people being sick. I think in our own trust, we had about 6 pregnant women or recently delivered in ICU across our 3 sites. So there was a big peak there. And what was upsetting at that time was some of those women had been eligible for vaccination and weren't vaccinated. And we knew that a lot of people, died in that wave who could have been protected because they were scared. And I think as it went on, everybody I met who had a complication of COVID said, I thought I could wait till after I had my baby. And there they were in with a pulmonary embolism or with some other complication. So, that's been my experience.
Thank you, Teresa. I think that's a really poignant point to finish on, actually, that I remember that period. I remember talking to you during that period, and so many of the women who were really very sick were the unvaccinated ones. I'm going to bring Viki Mail in now. So Dr. Mail, you're an immunologist and you've got an interest in pregnancy. And can you tell us, is the vaccine safe? There's a lot of concerns about it affecting fertility, affecting baby. Can you tell people the right information so they can make the right decisions?
Yes. So I'm going to start with pregnancy, but I will talk a little bit about fertility if I've got the chance. So as you know, as we've heard from Christina, as we've heard from Teresa, If you're pregnant, you are at higher risk of COVID. You're more vulnerable yourself. You're more likely to need intensive care. And if you do get ill, it increases the risk of preterm birth and stillbirth for your baby. And so, of course, we would really like to avoid catching COVID if we can when we're pregnant. And if we do catch it, we would like it to be as mild as possible. And that's what makes vaccination in pregnancy look so attractive. And this is why right now, if you're pregnant, you'll be offered a COVID booster, even though most people who are pregnant are under 50, which means that they wouldn't be offered it ordinarily just because of their age. But of course, a question that people have is, okay, well, I completely understand that it's bad to get COVID, but is it safe to get the vaccine? And because it was so important to be certain of the safety of these vaccines in pregnancy, actually a lot of work has been done on this. And so the headline is that among more than 330,000 people vaccinated in pregnancy across 8 countries and followed up in 29 studies, there's no increased risk of any pregnancy problem associated with COVID vaccination. And quite often when I tell people that, they're surprised that so much has been done and so much is known about this. But it's important, so we needed to be sure. And we've now had enough time to get a significant number of people who've been vaccinated in the first trimester of pregnancy through these studies too. So we have enough data to be confident that there's no increased risk of miscarriage or congenital abnormalities associated with vaccination in the first trimester, as well as no increased risk of things like preterm birth and stillbirth that we might be worried about later on. And in fact, 2 meta-analyses have found a decreased risk of stillbirth in people who are vaccinated during pregnancy. This might make sense because as we've kind of already alluded to, COVID infection can cause stillbirth. So it might make sense that vaccination could prevent that from happening. But the data is probably also a little bit influenced by the fact that people who follow medical advice to get vaccinated during pregnancy will also be following medical advice in other ways. And so they might be doing better because of that. And finally, I think it's worth mentioning that another potential benefit of getting vaccinated during pregnancy, which Christina alluded to, is that there is some protection from for your baby. So that's a kind of like 2 for 1. Now, some studies have looked to see if the vaccine itself can cross the placenta, and they find that it doesn't. But the antibodies that your body makes do, and that's why we get that protection from COVID infection for your baby. But to be clear, the reason that people are being offered a booster and the reason that we would really encourage them to take it up is not to protect their baby after the baby's born, which is why we'd be offering you a whooping cough vaccination, but rather to protect you and your baby while you're still a sort of single unit during your pregnancy from these things that can happen if you end up in intensive care or preterm birth or a COVID stillbirth. Before I kind of finish talking about vaccination in pregnancy, I just want to touch quickly on the flu vaccine in pregnancy. Christina mentioned that we're kind of having a little bit of an early flu season, it looks like this year, but we are behind where we were last year with people taking the flu vaccine if they're pregnant. So we've got 15%, sorry, we've got a 12% uptake so far. This time last year it was 15%. So also important to protect yourself against flu if you're pregnant.
Thank you, Viki. I just wanted to ask, there's a lot of misinformation out there at the moment, isn't there? And a lot of, I don't blame women for being scared when they see that. Have you got any words about some of the stuff that's on social media?
Ooh, I've definitely got words. I suppose what I would say is that there are some people out there who have an agenda, and they tend to target people who are vulnerable. And you can see why they would target people who are pregnant, because they're more worried than other people of their age. They've got their baby to think about as well. And I would say the real thing to do is to go to a trusted source of advice. So I would always recommend the Royal College of Obstetricians and Gynecologists. They have an amazing FAQ about the COVID vaccination and pregnancy that's regularly updated. That's a brilliant resource if you want to find out what's really going on. And the NHS pages as well are a useful resource. And you can also talk to your midwife or your doctor, who will be able to ask any slightly more, answer any slightly more, specific to you questions that you might have.
Wonderful. Thank you, Viki. I'm going to hand over to Zubaida now for the next part of the session.
Thank you very much, Binita, and thank you, Dr. Mail. Now, as I mentioned, we're delighted to have Dr. Nighat Arif with us today. And Dr. Arif has a special interest in women's health, but also does a lot of work ensuring that important health information is accessible to people from all backgrounds. Dr. Arif, we saw some of the really worrying data that Professor Christina Pagel shared with us about uptake of vaccines in relation to pregnant women. And in particular, what was worrying was pregnant women in deprived areas, as well as Black and ethnic minority women, but specifically Black women. I wonder if you could tell us a little bit more about what some of those issues are in relation to COVID health and pregnancy and COVID vaccines in relation to Black pregnant women and women in deprived areas.
Hello, good afternoon. Thank you, Zubaida, for having me, and it's a real honour. I completely firstly echo what Christina, Viki and Teresa have said. Please get your COVID vaccine and also your flu vaccine. I've had them both and they're absolutely safe, and I've had no side effects from them either. Before I answer that question, because it's a rather complex question, I think we need to go back a little bit and look at how we've had long-standing mistrust and lack of representation for Black and Asian communities. So when you don't see yourself represented, people that look like you, sound like you, are not on your everyday posters on social media, and then this new novel vaccine comes along, well, actually what you do is you introvert back into your community and say, well, do they represent my interests? So we have to go back to the mistrust, which is triggered by studies such as the Tuskegee study, which ran for 40 years from 1932, unquestioned Nigerian children who had the experimental vaccine, the anti-meningitis vaccine, which left 11 children dead. And the ethics around that study and the questionable consent that was taken from parents, unfortunately, stories like that travel within communities. We tell each other stories often, especially if English is not your first language, and they stick in the community. So the meningitis vaccine trials that were done in Nigeria was back in 1996. So that's still very, very prevalent. And then if you look at sort of studies in regards to pregnancy in this country, you're looking at the MBR race studies, which shows that 5 times more likely Black mums are going to die from childbirth and pregnant and birth complications, and Pakistani or South Asian communities twice more likely. So you've got that historical mistrust already. I worked in Slough, so for about 10 years, looked after a lot of my Punjabi community. And if I ever saw a poster for a mum to come and have her antenatal checks, or for a woman to have ovarian check, or, you know, a review, or to come and get your smear, or the signs and symptoms of breast cancer, it would always be a middle-class white woman that I would see in any of those posters, none that look like me. And then when COVID came around, the the information that came originally for all the public health messaging was, again, white middle-class individuals. In my community, if I went into mosques, none of them thought that the virus would ever affect them at all. And because none of the messaging was evolved around them or delivered to them in a language that they could understand. And it was almost seen as this isn't going to affect us. And that went into the community for when women were trying to get pregnant, breastfeeding, or thinking about getting pregnant. And what we found that actually at the start, 79% of individuals from Black backgrounds were saying we're not going to have the vaccine, which obviously, knowing as a doctor that works in the NHS and doing women's health, I thought this is going to really detrimentally affect us. Team Halo UN initiative was set up at the time, which had 70 doctors from around the world. And I was part of Team Halo to look at how we can get the messaging across, 1, from verified individuals, 2, that there's no misinformation, and we are stamping out misinformation on social media. YouTube, TikTok, Facebook, and Instagram also came on board with the UN initiative, because this is a global problem. Because at the start, the studies there was very few Black and Asian women that were included in the study trials. So how can you say that Black and Asian women are safe? And then also when women had the vaccine, their periods will either become irregular as well. And that also caused a lot of fear, and very genuine fear, especially if you come from a community that's not represented anyway, and you've had experience of health inequalities. We can't sit back and sneer and belittle that lived in experience until you've had it. the great thing is by Team Halo, by producing TikToks, and I produce videos in Punjabi and Urdu for individuals in our community, going into mosques, going into places of their place of trust. We were able to break down some of those myths that we had, and the uptake of the COVID vaccine did increase. And in 2021, when I presented our Team Halo data at the G7 summit, it showed that Black and Asian communities need to come on board, because this is not an individual problem, this is a global problem, and we can do it. We need to, so the good things is that we need to enhance our uptake of digital platforms and be able to get the right messaging out there. As Viki was saying earlier, we must be stamping out misinformation, because it's the vulnerable groups, such as Black and Asian groups, who have difficulty getting the right information all the time. We need to be encouraging Black and Asian women to have the confidence in the vaccine, taking vitamin D, making sure that they're getting the flu vaccine as well, and also showing them that there's no long-term harm done, because communities have had issues with other unethical trials being done where the problem wasn't at that time, but years down the line, where they actually saw the outcome, detrimental outcome, which was traced back, such as I say, the meningitis vaccine. So there is great work that is happening. We just need to continue doing more of it. And at the moment, I think that the uptake is getting better, but definitely we could do more.
Thank you. That was fantastic. And I'm really pleased that you raised the issue of mistrust, because I think to this day, that's not really been taken on board. And in terms of misinformation, there's still not been a real national campaign around it. And so I was going to very, very quickly ask you, it's fantastic the work that you've done with the UN. I think you said was it called Team Halo? Yes, fantastic work. Do you think that should be a national campaign?
Yes, I definitely do. So YouTube have now started to launch something called YouTube Health, which I'll be part of, which will be on the 9th of November next month. And they're trying to do a similar program, because what came out of the G7 summit when the vaccine confidence was that this is a global issue in regarding trust and getting people who look like you, speak like you, represented. And this is in the national interest. So an individual like me, who wears a hijab, is Pakistani, speaks Urdu and Punjabi, women find that they trust women that talk like them, and you can't deny it. And also you feel that you can replicate that. So this is on a larger scale, where we need to be tackling racial bias, racism, misogyny, sexism, Islamophobia, because I can say I've had lots of, unfortunately, trolling because of just me being on a TV platform. But then out of that comes trust, because women feel, actually, if Dr. Arif is saying this, she's looked at the data, she is an NHS doctor, I'll be believing that more than anybody else. And that is literally as simple as it gets. So in the national interest, we should be making a lot of noise around this, actually, because it's for the greater good, I believe. If we know that we've got a woman protected, she's not going to get severe outcomes from having COVID.
Thank you. That's absolutely fantastic. Binita, back to you.
Thanks to Zubaida, and thank you, Nighat. That was really fascinating. So last but not least, we come to Dr. Louise Newson. I'm delighted you can join us, Louise. And we're slightly changing tack now, because we're now talking about perhaps how COVID affects women more generally, particularly those who are suffering from long COVID. I know you're a menopause interested GP, but you've done a lot of work around understanding the impact of COVID. Can you tell us a little bit about what you're seeing?
Yeah, absolutely. So thanks so much for inviting me today. There's two areas, actually, just to pick up on COVID first. Some people might know I've also got a pathology and immunology degree. So I'm very interested in the immune modulating effects of estradiol, because obviously a lot of inflammatory diseases increases as we don't have hormones when we're menopausal, including heart disease, osteoporosis and so forth. But also our immune function doesn't work so well. Ever since COVID first started appearing, when they had those awful photos of people that had died from COVID at the start, a lot of men, obviously, we knew. And then I kept saying to my husband, who's a doctor, I'm sure COVID is going to, hormones have an effect here, female hormones. And he just said, when you just be quiet, all you ever do is think about female hormones. And then there was a young girl that died who was in the newspaper. And I said, I bet she has got an eating disorder. She looks very thin. She won't have the same levels of estrogen in her body. And he kept saying, stop it now. Anyway, fast forward 2.5, 3 years, we do have evidence that women who are menopausal, who don't take HRT, have a higher risk of mortality, more severe COVID. We also know from data from many different countries now that women who take HRT have a lower risk of dying from HRT, and it's just significantly statistically different, and also less severity. I haven't actually yet met an ITU consultant who's admitted somebody, a menopausal woman taking HRT, in their ITU unit. And it's no surprise. We know that estradiol can genetically reprogram our immune cells. It can increase their number, increase their efficiency. So that's basic science. It's just been forgotten in the whole WHI scandal of the WHI study and HRT, people worrying about breast cancer. So more and more data has come out all the time. And I think this is really important when we're thinking about if COVID increases or if another pandemic. So that's something that's really important, just as an aside, really. And then we also know the way the coronavirus affects our cells, as you all know, it affects our ACE2 receptors, but also TMPRSS2. And both of these are modulated by estradiol, and we have a lot of ACE2 receptors in our ovaries. This is very important. So estradiol actually obviously works to improve our immune function, but it's very specific when you look at COVID. This is really important as well, because our ovaries seem to be damaged more when we've had a infection with coronavirus. And all of you, I'm sure, know that any infection can affect ovarian function. The last thing a woman wants to do is become pregnant when she's got an infection. So the body can protect itself from infection. But also because the number of ACE2 receptors on our ovaries, I often probably means that our ovaries are being damaged a bit more with the coronavirus infection. Not for every woman, but a lot. So then when we think about long COVID, there are probably two mechanisms, I think, going on. One is that women probably have worse symptoms because their estrogen, but also testosterone levels reduce quicker because their ovaries are damaged by the coronavirus. But also, over the last couple of years since COVID, there will be women who are perimenopausal and menopausal. So how do we know which women have got long COVID and which women have got just perimenopausal or menopausal, or indeed which women have both? It's very difficult because, as you all know, there's no, despite what Boots and Superdrug and the other chemists try and tell us, there's no test for the perimenopausal or menopause. There's no hormonal test, whether it's a saliva test, a blood test, a urine test. They're not sensitive or specific, so there's actually no point doing them, whatever age a woman is, even when she's young. FSH tests are very unreliable as well. So there's also no biochemical test for long COVID as well. If you look at the symptoms of long COVID and the symptoms of perimenopause and menopause, they're pretty much identical, even symptoms such as lightheadedness and dizziness standing up, and fatigue, reduced stamina, headaches, joint pain. They're people, we see over 4,000 women a month through my menopause clinic. These are symptoms we see all the time in perimenopausal and menopausal women. And we know they're related to hormones because when we give them hormones back, these symptoms improve. So then my big question is, how many of these people with long COVID actually are perimenopausal and menopausal? And about 18 months ago, we just did an internet survey. It was only done for a short period of time, but we found that 70% of women, when you ask women themselves, because women aren't stupid, they actually thought that their long COVID symptoms were contributed by their hormones. Excuse me, because a lot of women were saying when they've got periods, their symptoms of long COVID are worse before their periods. And we know physiologically that's when our estradiol levels are lower. But a lot of women also just, it's a gut feeling, they know it's related to their hormones. What really excited.
Yeah, I'm so sorry to interrupt you. We've got some questions from the public. So I just wanted to ask you, because I know you're really passionate about this topic, just very, very briefly, What should women be doing if they feel that they might have these symptoms and they're not sure?
Yeah.
What piece of advice?
It's a really good question. It's not just women, but healthcare professionals as well, because it is really difficult to know. I think the most important thing is for women to be empowered with information about the perimenopause and menopause, so they can download the Free Balance app, create a health report from it, which has symptoms and ability to monitor periods if you're still having them, and then talk to a healthcare professional about, should I just rebalance my hormones as well? So HRT is very safe. The body identical hormones, there's no risk of clot, which is really important when we think about COVID and long COVID. But also testosterone is a hormone that we produce from our ovaries. We know we're allowed to use it if women have reduced libido, but actually our clinical experience tells us that mood, energy, stamina, concentration, even symptoms related to POTS as well can improve. So I always say to women I see with long COVID, look, I have no idea which symptoms are which, but I do know you're perimenopausal or menopausal. So let's rebalance your hormones, both estrogen and testosterone, and see what's left. And I now have a lot of women who say, well, I think I'm in remission from my long COVID. But even if we only get people 20% better, it's better than what they are now.
Absolutely. So bottom line is a trial of hormones, probably nothing to lose, quite a lot to gain. So discuss it with your GP. Right. I'm so sorry we've overrun slightly. I hope we've got time for all of our public questions, but that was such a brilliant conversation. Back over to you, Anthony.
Thanks very much. Well, let's go straight to our first questioner who's joining. That's Helen Essex. Helen, the floor is open to you. Welcome.
Hi. I think some of this might already have been answered, but my question was more around social impact of COVID on women. And I was thinking, could the panel tell me if there's any data as to whether women are more affected by long COVID, either medically, or I was thinking more in terms of the work that women perhaps more predominantly do, like as cleaners or working in care homes, nursing, TAs. Are we experiencing COVID more? And then because we have caring duties, is it impacting us more in terms of not being able to go to work or looking after people with long COVID, those sort of wider issues? Thanks.
That's a really important question, actually, about who would like to take that. Is that something for Nighat or Louise?
Yeah, I'm very happy to answer that. And it's a really, really important question. So we had a paper published in The Lancet, actually, about sex differences with COVID and long COVID. And there have been groups of people looking to see, is it because women are more frontline, you know, in shops, teachers, nurses, like you say, working in care homes. The data's a bit uncertain. We don't know. But certainly that's one of the reasons that we were looking at, because when we say menopausal women without HRT, which is the majority of menopausal women, of course, because most women don't take HRT, people were saying, well, it's just because women are more in these front-facing jobs. But when you look at the differences between those on HRT and not, there definitely is a difference. And we also did some work with Tim Spector showing women on the contraceptive pill less likely to have more severe COVID. So it's really difficult, isn't it, to know for sure, because there's so many variables in this. So all you can do sometimes is speculate. But it does show the importance of women with facing jobs to actually do anything they can to improve immunity. So it's really important.
One figure I saw, Louise, one figure I saw recently is that women are twice as likely as men. That's nearly half of women who have to take leave to look after sick children, take unpaid leave.
Yeah, absolutely.
So children getting infected has an effect on household economy and may also affect on food intake. So, I mean, the whole thing is really cut. Anyone else quickly on that? Zubaida had your hand up. Quick response.
That was a really good question, a really important one, Helen. There's actually quite a bit of research out there. And last year when we discussed the impact of COVID on women, we had the Women's Budget Group who've done lots of research on this and looking at the economic impact, social and economic impact. The women's charity sectors like Fawcett and others have also done some work in this area. There's no question that women, while they experienced it differently also in terms of socially and economically. It has had quite a profound impact. And that's, as we mentioned, in terms of childcare, we know that women have disproportionately had to take over childcare, even when they're working women. So they've had to do that during the pandemic. But on top of that, we know that working class or low income women have really taken the brunt of the pandemic economically. And that's because of the type of work that they do, as you say, more likely to be in care, more likely to be on front line, more likely to be in single households, running single households and so on. They've really been impacted on this enormously. But as I've said, if you're interested, there is quite a bit of research out there. You can start with Women's Budget Group.
Thanks so much, Helen. That's a great question. Do you know at Prime Minister's Questions on Wednesday, not a single question in half an hour came in about women's economic status or the fact that a quarter of children are hungry in the UK or in a household where there is hunger. I couldn't believe it. I rant about this on Twitter, but thank you for asking that question. It's so important. Let's go next to Elizabeth, if she's here. Have we got? Yeah, we have got Elizabeth. Welcome.
Hi there, thank you. Thanks you all for what you do and for taking my question today, which is what is known about the effect of COVID vaccines on menstrual cycles? For example, more frequent, heavier, and longer lasting periods, as I've experienced. How long may these effects be experienced after vaccination, and is there cause for concern? Thank you.
Great question. Who would like to take that? Is that Viki?
Yeah, I'm probably a good person to take this question because I have done research in this area myself. And one of the big difficulties of doing the research in this is that actually periods do vary quite a lot anyway, but also we tend not to talk about our periods. And if one thing maybe good comes out of all of this, it's that we should talk a bit more about our periods in the future. But it made it really difficult to know when people started to say, oh, hey, I've noticed this change to my period, if it was a change that was happening because of the vaccine, or if it was one of this normal variation of changes, or indeed a change happening for another reason that we just wouldn't have otherwise been talking about. But now we do actually have some really solid data from 4 studies, 3 of which use thousands of people who have put their data into menstrual cycle tracking apps, just to keep a record for themselves. And then we asked them, okay, can you tell us what day you had your COVID vaccination? And using that data, we've been able to tell that in the cycle after, or rather the period after your COVID vaccine will be delayed on average by between half a day and about 2 to 3 days. And that 2 to 3 day delay is mainly in people who have both doses of the vaccine in the same cycle. And the half a day delay is the rest of us. But importantly, what these studies have also shown is that the timing of the periods go back to normal, either the next cycle or the cycle after. None of these studies have been able to find any difference in how long the period would be. And there has been one study which didn't use a menstrual cycle app tracking approach, which did find that you're about twice as likely to have a period that you would think of as heavier than usual after you've had your COVID vaccine. But again, there's some evidence unpublished that suggests that this all goes back to normal the next cycle or the cycle after. So I think the important messages here are the evidence does say that COVID vaccination can temporarily change your menstrual cycle. The changes are quite small compared to normal variation, but they do happen. But they do go back to normal quite quickly in these studies of sort of thousands and sometimes tens of thousands of people that we've seen. So what that would say to us usually is if someone comes along who says, I've got this change and it's going on and on and on, we would start to think that's not actually a vaccine mediated change. That's something that you should really go and get checked out. And so if that's something you're experiencing, I really hope that you have a GP who you can talk to about it and who you've approached about it and who is helping you out, because we would worry that something else is going on there and you want to find out what and you want to get that treated.
Viki, thank you very much. Very comprehensive. Thanks for that question. I'm going to move on because we're running short of time and there's quite a few questions that we have. Thanks, Elizabeth. The next is from Julia Smith. She asks, is it true that there is documented evidence linking increase in heart attacks, blood clots in coronary arteries with the mRNA vaccines? Has data been hidden to get people to have the vaccine? I have had it and been supportive, but I'm hearing an NHS cardiologist, explaining the link. I am now concerned. There are some people here, I think, that may want to have a word about that particular cardiologist who most of us believe is not representing science fairly. Anyone want to take that? Sheena, Professor Sheena Cruikshank.
So this is a really unfortunate set of disinformation that is being circulated at the moment. One of the things that is being circulated quotes from a study that came out earlier this year. That study was looking at the effects of vaccination versus nothing at all, basically a placebo. It wasn't looking at the impact of COVID. And that is really important because any medicine, any drug could have slight risks. That is well known. But when you're comparing that possible risk with the actual harms that a disease can cause, there's a huge difference. So that is one of the first things. And the other thing is that they're talking about a cumulative set of possible harms, ranging from everything as mild as a little bit of diarrhea all the way through to possible myocarditis. And myocarditis is not just a one-fits-all type of phenomenon. It means inflammation of the heart muscle, and it can be really, really mild and resolve very quickly, or it can be really serious. And actually, vaccination has been associated in younger males with a slightly raised increase of mild myocarditis that is resolved, whereas COVID disease is associated with 11 times more risk of severe life-threatening myocarditis. So the risks from the vaccine are nowhere near as severe as the risks from having actual COVID itself.
Thank you very much. We could have others on that, but let's not go further at the moment. It's very regrettable that certain members of our profession speak out without representing the science fairly. Thanks for that clear explanation, Sheena. Next is from Amanda Botting. Is there any evidence so far regarding COVID leaving some people with chronic, very painful musculoskeletal symptoms? I think that might be one for Helen. Have you seen that in your practice at all? Or do you know of any evidence?
What I have seen is what appears to be some sort of reactive arthritis following COVID infection. So some people have inflammation of their joints, which comes on after other infections. We've known this for ages. You can get in a reactive arthritis after gut disease. You can get it after sexually transmitted infections. All sorts of things can give you a reactive arthritis. And it does appear really quite clear that patients get this sort of arthritis sometimes, which is a sort of autoimmune arthritis, but it does tend to go away. But it does seem, really early on in COVID, I saw quite a few reactive arthritis for joint inflammation due to COVID. So it is definitely a thing. I don't know about other muscle pains. I haven't heard that so much, but I think it may be more of a long COVID thing. And I think Binita looks like she's got something to say about that.
Thanks, Helen. Binita.
Yeah, no, we're definitely seeing that with long COVID patients. And as Helen has said, there's reactive arthritis. There is also some patients who have activation of the mast cells, which are involved in allergic inflammation, and that can cause joint aches and pains. But we are also seeing, so I saw somebody in clinic recently who was behaving very much like they had a vascular disease of the legs, much as we see in long-term smokers or diabetes, it almost has this what we call claudication. So I think there's probably a number of different mechanisms via which these aches and pains can happen, and we're starting to understand more and more about it as the research comes out.
Thank you very much. Right, the next question from Keith Baverstock. Are those reporting themselves as long COVID patients more susceptible to contracting a second COVID infection than those who recovered fully from a prior infection or who had one or more COVID-19 vaccinations? In other words, does having long COVID increase or decrease the risk of contracting the virus a second time? well, as someone who had long COVID and still has some symptoms, I did get the virus a second time, but that's a sample size of 1. Steve Griffin.
I don't think there's any evidence that says that having long COVID does anything to your susceptibility separate to your actual immune response. But there have been some studies, in fact, there's a study out this week that shows that if you've already been vaccinated, and this isn't a very good way of achieving immunity, I should mention, but the more severe your breakthrough infections are, the more vigorous your anti-SARS-CoV-2 immunity is after that. So that fits with a lot of other diseases. Flu does that as well. If you have very mild flu, you don't always seroconvert. Children don't always seroconvert to SARS-CoV-2 either, but for that same reason, they have a vigorous innate response and they get rid of the virus very quickly. So the severity of your previous infection can relate to your immunity afterwards, but ideally vaccines, or at least vaccine first if you're talking about hybrid immunity. But I don't think there's any evidence that long COVID either makes you more or less susceptible to subsequent infection.
So it doesn't, right? Anyone else on that? Okay, no, let's go on. One more. I think we've got time for just one more. Why are vaccines for children available in the US but not in the UK? Anyone? Arif, Steve again.
I think Sheena had her hand up first.
Oh, Sheena.
Okay. No. Oh, okay. Go on.
You go, Steve.
That's a very good question. I'm not sure I really know the answer. I'm not even sure that they've done that assessment yet. So JCVI are the body that assesses the use of vaccines after they've been approved in terms of safety by the MHRA. Now, the UK has been a bit of an outlier in terms of the time it takes to go from that safety approval through to the use and application. And it's very upsetting to see that the offer to kids under 12 was a one-off, and that's now been stopped for kids turning 5 as of this September going through. Nowhere else in the world, apart from places like Denmark and places that have done that sort of thing, and they're still keeping it under advisement. So I think that, you know, with the amount of infections that we're seeing in young people, younger people are more likely to be infected more than once than older people. This really is not good. We can't rely on infection to generate immunity with a virus like this, because especially with the prevalence of Omicron, those rarer events when children get more unwell are becoming increasingly common, and that's not good. And of course, kids can get long COVID as well, as we heard about the other week.
Thank you. Final word from Christina, I think, on this issue.
Yeah, so I think, you know, there's a lot, people talk a lot about, oh, it's fine, we've all had COVID now and we're protected. Well, you know, children under 5 are the least likely to have had it, and they're getting born all the time, and they get born without immunity. And if you read the minutes of the JCVI, when they discuss children, they seem to believe that COVID's not bad, so they don't feel the need to vaccinate. And I imagine that's also behind, there's no urgency to consider vaccination for under 5s. Now, they're very different to other countries in that. I don't think it's the right approach at all, but I suspect, to be honest, that's what's behind it.
Thanks very much, Christina. Thank you all to all our experts. To Sally O and Annie McLean, thanks for your questions. We will answer them next week. We'll carry them over. But we are at time. Thanks so much to all the people that asked questions. Thank you all for joining, and we hope to see you again next week, same time, same place. Till then, keep safe and get a booster if you haven't had one. Bye.
Flu.
Thank you.
Yeah.
Bye.
Bye.
Flu
Bye.
booster.
Flu.
Yeah.
Flu and booster.